Okay, hello, good evening, everybody. My name is Alec O'Dare. I'm the managing director for Wound Care People. Apologies if there was a bit of a delay just then. That's the beauty of going live. So there was a very slight technical issue. We're presenting from our homes this evening, as you can see. So do bear with us if we get any more of those. Tonight's session is setting standards for leg ulcer care. It's a Welsh perspective. I'm very pleased to be joined here, both from Cardiff, by Kirsty Mahoney, who's a senior tissue viability nurse specialist and operational program improvement lead at the Welsh Wound Innovation Centre. Hello, Kirsty. How are you doing?
Oh, nos with dda, Alec, nos with dda.
That's with us, you too. It's I think I was wondering whether this is the first. No, this is definitely not the first time I've done this with somebody in Wales, but it's certainly the
Yeah,
first time I think that we've done it both from. We've done one
from
together,
home.
but
Yeah,
never both in Cardiff at the same time. So
absolutely,
this is a
absolutely.
this is a Welsh massive first. So
Flying
this
the
is good
flag for
news.
Wales, definitely.
Exactly. Okay. So, Kirsty, you're going to be speaking this evening on behalf of
Yeah.
the All Wales Tissue Viability Nurse Forum, which is essentially the group of all of the tissue viability nurses who work across all of seven of the LHBs here in Wales. And together, you've worked on creating a document, which is essentially setting standards for leg ulcer care across Wales, which we've been helping you to produce. So that's quite exciting. That's about the gist of it, right?
Yeah, definitely, definitely. And I think it's a really exciting opportunity. I'm really excited to present this overview of the All Wales Tissue Viability Standards for Leg Ulcer Care. I think we're going to be formally launching it next year. And we all believe that the document will give a 360 practical guide for leg ulceration and leg management for patients from initial assessment and beyond. And there's some really helpful resources within the document to assist both healthcare professionals and the patients through their leg ulcer journey.
Fantastic. And the and so just for those people who are watching from outside of Wales, this is relevant to everybody because ultimately
Yeah.
what the event today is about how multiple multiple groups, so people from across different health boards have come together to say actually we should create one single standard. So that tonight is about leg ulcers, obviously, but it's also, and probably more importantly, about how you can come together with your sort of local, your local colleagues from other trusts and from other areas to create standards that will basically define the way that you treat wounds, and in this case, in particular, leg ulcers. So, what our involvement essentially, we're an events and publishing business, and our involvement has been to help you. You've created the guidelines, you've come up with them, and our
Mm-hmm.
involvement has simply been to edit those and put them into a readable, digestible format. So we've been basically publish it. We've put it into a publishable um, document, which will be available to everybody, I think, in January. We can't do that without the support of industry. I think that collaboration with industry is really, really important for for the NHS. And we've worked with this, or we've worked on this with Essity, LNR, Medi, Sigvaris, and Haddenham. So they've all supported this document. We're really looking forward to hearing more about it. So as always, certificates will be available at the end of the presentation via a link that my colleague Lindsay will put up during the chat. Please do ask as many questions as you possibly can because I'll be coming back after the presentation to do the Q&A with Kirsty. And just as I said earlier, do bear with us if we have any technical issues. There shouldn't be any. We've done lots and lots of tests despite that very first moment. So, Kirsty, I'm going to hand over to you so that you can get on with the presentation. Good luck, and
Thank
I'll
you.
be watching here, and I'll see you in about half an hour ish, and we'll see what questions have come up. Okay, good luck.
Fabulous. Thank you. Thank you. And as I said before, nos wyddar, everybody. And if you would like to ask any questions, obviously you can comment on the video as we're going along, and Alec will pick up the questions and we'll do the Q&A session afterwards. So first of all, I think I would like to share with you who we are. Who are the All Wales Tissue Viability Forum? And we consist of 51 vibrant and passionate healthcare professionals, all tissue viability nurses representing the 7 health boards and the 1 NHS trust, which cover the whole of Wales. And we're accountable to our Chief Nursing Officer for Wales as well. We have various work streams to produce guidance and advice on all aspects of tissue viability across Wales. And the Leg Ulcer Standards is one of our newest documents, and we're really excited about the launch of it next year. And I'm sure that as I go along in the presentation, you can see how important it will be. So first of all, let's have a little bit look at what leg ulcer in Wales and across the UK really is like. So if we look at the national cost of venous leg ulceration in Wales, a study by Phillips et al. In 2020 indicated that leg ulcer care represented about 1.2% of the NHS budget annually, and that's a significant cost. And not surprisingly, or surprisingly for some people, the majority of costs were linked to nursing time rather than resources like dressings. And this actually equated to 67.8 million per annum. And these high figures have also been reported by Guest et al. In England, so it's no surprising. However, the actual treatment costs are likely to be much higher because we know that we've got potential variation in how people record leg ulcers, and also we've got a lack of accurate diagnosis. But of course, we can't underestimate the costs to the individual, which is substantial, and it's usually part of substandard care, and it leads to maybe years of suffering and pain. And it can have a very detrimental impact on an individual's mental and physical well-being. So last year, we did actually do a little snapshot of what was happening across Wales. So we did some randomised assessments of what was going on in district nursing bases and community-based wound care services that manage leg ulceration. And as you can see, there's no surprise that venous leg ulceration accounts for half of the leg ulcer etiologies. And I think that's reflected in most studies that you see. But to me, the most concerning thing is that 26% of these individuals had an unknown diagnosis. So if they've got an undiagnosis or a lack of diagnosis, how can we actually deliver evidence-based care? So if we don't know what's happening with the patient, how can we deliver that evidence-based care? So I think really that's the background of why we need to form standardization in practice. And we know that delayed healing is obviously is usually a result of suboptimal care. For some reason, I don't know why, best practice guidelines exist but are not always followed in some cases, and this leads to avoidable morbidity and reduced quality of life. And we know that improved healing rates can be improved through accurate and early diagnosis and rapid commencement of evidence-based treatment pathways. So let's have a little look at our standards for leg ulcer care in Wales. So in England, we've got the National Wound Care Strategy, and their drive is to reduce variation and promote standardisation. And the All Wales Tissue Viability Leg Ulcer Standards have been produced to reflect this and to be easy to follow, adds this consistency of care and reduces that variation and optimises a patient's potential for healing. The principles laid out in the standards will be discussed further on and supports that ethos of self-care, where appropriate, and assist in minimising recurrence and lead to hopefully financial savings in the NHS in Wales. However, this document is not just for use in Wales, and we're hoping that it can be adapted in lots of places because it can be used to provide practical advice in a variety of healthcare settings on the assessment and management of leg ulceration. So The best practice standards provided in this document promote that effective early intervention that is key to the prevention of disease progression, reducing the risk of cellulitis, and improving those patient outcomes and healthcare deliveries. It also acknowledges that benefit of appropriate immediate first-line reduced compression, even in the absence of overt signs of venous insufficiency. The document also guides patients and carers to the standards that they should expect and a range of care strategies that are available, including care options. And I'm sure that you agree that patient concordance and patients being involved in care is so much part of what we do and should be encouraged. So what does our standards look like? So first of all, we've got an introduction. We've got our initial contacts. We've got what we should be doing at 2, 4, and 8-week reviews. Some guidance there on compression therapy and also a glossary of terms. In our appendix as well, we've got lots of sort of standardized documentation that you can use in practice and lots of information that you can give your individuals as well. And I'm sure that you'll agree that one of the things that's so difficult, especially when you're thinking about auditing practice, is about that standardization of documentation. Otherwise, you're not comparing the same things. So it's got lots of interesting and very relevant guidance to help you in your clinical practice. So firstly, in our introduction to leg ulcer care, the document first defines what a leg ulcer is. And it's a universal sort of definition that we use. So it's a leg ulcer is defined as a break in the skin below the knee, which is not healed within 2 weeks. And as we know, we've got a little bit there about epidemiology. It's the most common chronic wound, and it's more common in the elderly as well. So we know the risk of developing a venous leg ulcer rises with age. And with people living longer, the number of elderly population developing a leg ulcer is likely to increase. So that's more important that we get that prevention and intervention strategies right at that first assessment to ensure that we get those or avoid those complications we get with a chronic wound. So let's have a little look. So this is the initial contact assessment. This is what we advise. And there is a really nice initial contact form to fill in. Again, that's about standardizing the documentation that you use. So when a patient first presents to you, you will obviously take an initial assessment. Obviously, sometimes you may not have time to do that vascular assessment using ABPI, which is the gold standard. But on first presentation, this may not be possible to do. So firstly, consider the arterial risk factors and red flags where compression may not be appropriate or may be contraindicated. And this is where it may prompt you to think about what you need to do next and go on to do a full assessment, or maybe even refer on to appropriate people if you feel that there's a significant arterial involvement in that. And we also include in that guidance for referral should there be any red flags present. Obviously, if there's acute infection present, that will need immediate immediate treatment. And the document prompts you when you need to do immediate treatment for things like acute infection or maybe a DVT present as well. So we advise an initial assessment of the wound environment and determining those patient goals as well and their ability to self-care. This should be considered. If there are no flags, and we're going to discuss the red flags a little bit later on, the patient should be commenced in light compression. So by light compression, we mean 20 millimeters of mercury. And sometimes this has been something that healthcare professionals have been frightened to instigate. Certainly when I did my training years ago, one thing we were always taught is do not undertake any compression until you've done that arterial assessment. But now what we know through research is that if a patient presents and they do not have any red flags and they've got leg ulceration and they've got a lot of those clinical signs and symptoms of venous disease, start them in 20 millimeters of mercury compression. And of course, that will depend on limb shape, exudate, the patient's ability to self-care if appropriate. And within the documents, we've got guidance for compression according to the patient requirements. And as I said before, we have included within the document a standardized initial assessment form. So when we look at risk factors for venous disease, these are part of the simple tick box that we go on to include in our formal assessment. And it's really important to document those factors for venous and arterial disease. And it does help you decide or help you in your diagnosis with your leg ulceration. So important considerations when you're thinking about venous disease are increasing age, obesity or being overweight, issues with walking, limited ankle function, previous leg ulcers, personal family history of venous leg ulcers, history of deep vein thrombosis, unfortunately being female sex and multiple pregnancies, AV fistula, history of leg fractures or trauma, a history of IV drug use, chronic edema, a sedentary lifestyle and prolonged standing. So these are the things that we need to ask the patient when they present to us to help us decide whether they've got any risk factors for venous disease. When we're looking at risk factors for arterial disease and red flags for why we might not instigate that 20 millimeters of mercury of compression, we included things like MI, TIAs, transient ischemic attacks, diabetes, renal disease, rheumatoid arthritis, lupus, arterial surgery, smoking, pain on leg ulceration, intermittent claudication, pale, cool, hairless leg, and also a high capillary refill time as well. So if these factors are present, the document actually prompts you, as I will show you in the next slide with our red flags and contraindications, it will prompt you not to instigate 20 millimeters of mercury, but to go on and do a full vascular assessment. So some of the other contraindications for instigating any compression are if somebody's an IV groin injector, because they're more at risk of things like an AV fistula, and also an active or undiagnosed DVT. So they would be contraindications for you to instigate that first line 20 millimeters of mercury. So in summary, and we've summarized these in the document as well, what you need to consider when a patient first presents to you is that initial contact. So it's, complete the initial contact assessment form, look at those red flags, see if you can maybe instigate 20 millimeters of mercury, discuss with the patient whether they would like to self-care, and then complete a core care plan. And we've included some core care plans within the document as well. And we also have given some advice about basic topical management as well. So for example, if somebody's got a very exuding leg ulcer, you may not be able to put them in something like a hosiery. I mean, you may have to opt for a correct compression bandage system, which offers 20 millimeters of mercury. And you may have to include some padding on there to absorb the exudate. So we give you some basic guidance on what you should do from a topical management point of view as well. So as an aide-memoire and part of the document, here is an easy to follow pathway that's part of the initial contact assessment. I always think that pathways offer a clinician a very quick aide-memoire, and it helps the assessment process easy to flow. And it's presented in an easy to follow format. And throughout the document, we have included core care plans, both for the healthcare professional and the patient as well. And this aids consistency and ensures that the patient understands the care that will be delivered. So I'm sure that the patient assessment pathway, if it's printed in pathway, in sort of posters and put in clinical centres where it's easily, or a diary size one, it's easy to follow so that you know exactly what you should be doing when you're presented with an individual with a leg ulcer. So obviously in initial assessment, you don't have to do an arterial or a vascular assessment. However, that's not a cop-out for not doing a vascular assessment. So really, as soon as possible, and not longer than 2 weeks, we do need to do that formal leg assessment. Because remember, we've only put that individual in 20 millimeters of mercury. And we know that 20 millimeters of mercury is substandard for healing most venous leg ulcers. And we need to get them in at least 40 millimeters of mercury. So that assessment process at 2 weeks is really important. And it guides you then into doing your vascular assessment. So that's an ABPI or TBPI if you're able to do it. And also we've got guidance in our appendix at other sort of assessments that you can do in practice. So there's the Ipswich touch test, and we've got some diagrammatic assessment forms that you can leave, and also the Burgess test to assess for vascular disease as well. And we've got concise and really up-to-date information on how you can undertake these tests in clinical practice. The formal assessment at 2 weeks also gives you an opportunity to review the treatment that you've instigated and re-establish those treatment and patient goals, which is very important. And also within it, there is guidance as to if there are worries and the leg ulcer isn't responding as you thought, or it's not looking as it should do, then about referring to other disciplines such as vascular surgery. And again, within the NICE guidelines, it is advising you if somebody's got a leg ulcer, an active leg ulcer, they should be considered for venous ablation. So again, that's included within the guidelines. So the formal assessment at 2 weeks, we have a standardized documentation as well. So first of all, it guides you through assessing and recording the signs and symptoms of arterial and venous disease. And this is the opportunity to reassess the arterial and venous status as well. So again, the arterial status is, and arterial signs and symptoms is marked in red, and the venous signs and symptoms are marked in blue. So it's quite easy to guide you through that assessment process. And this standardized documentation reduces variation, and it also helps you to make that decision and assist in your decision-making process as to what product or what trajectory you need to go through for your individual. And the advice really, if somebody is undertaking that formal assessment at 2 weeks, it should be done by an appropriate trained professional. And I think that's something that we're not very good at, is skilling up our workforce for doing vascular assessments. And it's something that a lot of people are nervous about doing in clinical practice. But if you're treating someone with a leg ulceration, it should be something that you should be undertaking. And if you don't have the skills to do it, ensuring that you know where to refer to, if you've got venous ulceration or leg ulcer clinics available to you, referring to people that can do that initial assessment or that formal assessment with a vascular assessment. Because what we need to do is determine our diagnosis, and that will be placed on the clinical presentation and the vascular assessment. So we use all those signs and symptoms and all the investigations that we've done to come to our diagnosis. And then we can decide whether that's venous disease, arterial disease, or maybe they've got a little bit of mixed disease then, and maybe need some vascular assessment in that. So following our 2-week formal assessment, how often should you assess individuals with leg ulcers? So obviously you'll be informally assessing them each time they present to you for leg ulcer dressings. But we put some timelines in there to guide you as to when you should be doing those formal reassessments. So first of all, we've got a 4-week assessment, and then following that again with an 8-week assessment. So specific timelines are really important for monitoring that progress and identifying if that wound is failing to healing. And also we've got some referral guidance indicated in the document should individuals not be responding as we thought to standard treatment. Because here, if we've instigated that correct 40 millimeters of mercury, we should start to see those sort of individuals responding to treatment times and treatment pathways as well. And so, things that you need to consider is, how much has that leg ulcer decreased inside? Consider when you should refer to a specialist if somebody's in best practice treatment and not responding, and when you should refer to that vascular service as well. And I said before, NICE guidelines do indicate that you should give that opportunity to the individual to be referred to a vascular surgeon to see if they want to do any venous intervention to aid healing and also to prevent recurrence as well. So we think that within the documentation, it was very important to include something about the fundamentals of leg ulcer care for our venous leg ulcers. So what do we include in that, and how does that make it a holistic care? So things that we include within the fundamentals are promotion of co-production. So working with our patient to identify those shared goals. And I think to me, this is one of the most important things. Because if we fail to involve our patients early in that treatment trajectory, that's sometimes why we get that non-concordance later on within our treatment pathway. And it can be very frustrating for healthcare professionals when we've got somebody who's non-concordant. We've got a lot of information there. We need to be providing our patients with information and in an appropriate format that's easy to follow. So within the appendix, we've got lots of really nice leaflets in there that are easy to follow, and in a pictorial sort of process as well that are easy to follow as well. We also, as healthcare professionals, need to address those possible factors that could delay healing. We also need to provide healthcare promotion advice, so on obesity, managing diabetes and nutrition as well. All those things that can prevent healing. And we need to make sure that we optimize pain management, because if somebody's in pain with their leg ulcer, be it due to infection or something else, they're not going to be concordant with treatment. So it's making sure that we're managing their pain and their pain expectations in an efficient and an effective manner as well. But it's not just about us doing everything, it's about that co-production with our individuals as well. So promoting movement and foot exercises, giving them things so that they are very much involved with their care at home and they can share that journey with them as well. Other things that individuals can be encouraged to do, of course, is encourage that leg elevation when resting and trying to avoid that chair sleeping. And I know we have a lot of individuals that do struggle to get to bed at night, but of course sometimes that leg elevation at night is key in reducing that edema and reducing that exudate that's coming out of that limb as well. Sometimes individuals find it difficult to apply hosiery. So in it, we've felt that it was really important to support them and provide some aids and some advice on how best they can apply their hosiery. But also, we need to make sure within our fundamentals of leg ulcer care that we're recording local wound assessment weekly, or that 4-weekly assessment and 8-weekly assessment. And sometimes that's where we fail in care, is that we're not monitoring and recording the progress of our wounds very efficiently as well. So making sure that we're doing those full assessments and reassessing and referring if things aren't responding, or going back to that initial assessment stage and finding out, have I missed anything in that assessment? Is there anything I should be including? What have I missed? Why is this wound not progressing? Or have I misdiagnosed it? Is it a different etiology than venous leg ulcers? Is there a different thing I need to do? So going back to your initial assessment and doing that initial stage again and assessing those factors that it could impede wound healing. So this is something that we're asked a lot when we're giving training programs, is about, what should I clean the wound with? What should I apply to the wound bed? And it does depend on your local formulary. And, topical management and managing that wound bed and wound bed preparation is such an important, essential part of leg ulcer care. But also, we do often miss that care of the surrounding skin and that hyperkeratosis. And we know that very often this is a part that's missed out. And we see it in clinic all the time. We have leg ulcer patients coming back to us time and time again, and they've got that thick, horrible buildup of hyperkeratosis or skin plaques that need to be removed. So we've got a practical guide to skin and wound cleansing as well, which facilitates that removal of debris and hyperkeratosis. And in itself, that can reduce the risk of infection and biofilm development. And we've given generic advice as well on wound cleansing products within the guidance, as well as emollients. And as I said before, very often we're very focused on cleaning that wound and getting that sorted, but forget actually the surrounding skin is part of that holistic management of the individual. And also, we can get the individual involved in the patient in, doing some skincare if they're able to, applying that moisturizer and encouraging to wash all those dead skin cells off and getting the skin in a better condition. So that's really important. And of course, we know that in leg ulcer management, we like to keep it very simple. Very often we see very complex leg ulcer products put on in layers, and we don't need to do that. I think the best thing that we can do is keep it as simple as possible. Obviously, if there's a wound infection, we will need to respond to that appropriately. So if it's a local infection, we can treat that with a topical antimicrobial according to your local formulary. However, if it's a spreading infection or if there's sepsis, then we need to make sure that they've got the right antibiotic cover. And that may involve admitting the individual to hospital as well. So it's about looking at that evidence surrounding the topical application of products. And we've put in quite a comprehensive guide on what we should be doing with wound cleansing and topical application of products on the wound. So we know that compression is the cornerstone or the gold standard treatment, and it seeks to reverse that venous hypertension. And without that compression therapy, we're unlikely to heal a venous leg ulceration, or if we do, it's very lucky. And we know that high compression is required to maximize the healing potential of an individual. And we know it's out there, it's very substandard. And sometimes that's because that healthcare professionals are often unsure or not confident in which compression therapy is best for an individual. And also patients often do not understand why they're being prescribed compression. And therefore may be very resistant or non-compliant with care advised. So it's always best to get them on board as soon as they walk through that door, get them involved in their care, explain to them about what leg ulceration is, give them, as you can see on the screen, we've got some really nice pictures depicting what happens when you put compression on a venous ulceration. So get them involved in the journey from a very early stage so they understand what the treatment is and why we're doing it. So when it comes to clinicians, we want to put that high compression on. And what we need to do is look at those factors that may influence the choice of product and improve our confidence. So these are the things that may sort of influence what sort of compression we use. So for example, edema, exudate, limb shape, pain management, post-thrombotic changes, the height of the individual, obesity, psychological or lifestyles, and also availability on the wound formulary contract is really important. So within the guidance, we put quite a comprehensive guide together about what's available. And there are many different types of compression. And I think I was on a study day the other day, and I think there's something like 900 different lines of compression therapy. So no wonder we as clinicians get really confused about it. So as I say, a lot of it will be according to the limb size, shape and exudate. So for example, if you've got an individual with an abnormal wound shape that's got a high exudate, you're very unlikely to put hosiery on as your first line choice. So you may have to put them in a compression bandage system to shape the limb and reduce the exudate. And then you can step it down to maybe hosiery or a wrap. But if you've got somebody with poor dexterity, you may be inclined to put them in something like a wrap system. So, there are lots of options that you need to consider depending on the patient. So it's essential for us as healthcare professionals to select the right product for the right patient at the right time. And failure to do this can lead to deterioration or non-compliance. And very often we have individuals that come to us who've been in compression before and they say, oh, I'm not having that on. I had it before, didn't like it. So it's to sit down and understand them and understand why they didn't like it and maybe get them into something that's more appropriate and suits their lifestyle better. In Wales, we're quite lucky. So we've got a national compression garment formula, which helps us make our decisions. And all our bandages are included within our shared service wound management contract. So it does make our selection of compression products a little bit easier in practice. So managing patient expectations and concordance can be a really big challenge for our healthcare professionals. And as healthcare professionals, it's our job to empower patients to be involved in their care and, if possible, understanding their conditions and understanding how they can prevent and manage venous disease. And the role of compression in all of that is really important. We recognise also that patients and carers can play a very proactive role in self-care of leg ulcer management. And this document contains really vital information that can assist in increasing patients' knowledge in their management and future prevention of ulceration, such as examining what causes VLUs, the role of compression in treatment of venous disease, and what to expect when they attend for an assessment. We also include some exercises they can do to promote good healthcare and how to apply the hosiery. So we believe that involving your patient and giving them as much knowledge as possible can actually lead to that patient compliance and patient concordance. So thank you very much for listening to our overview of our leg ulcer standards in Wales. And as Alex said, the JCN and Wound Care Today have been very, really helpful in developing the document, but we couldn't have done it without our industry partners. So thank you again. And I'm going to pass you back now to Alec.
And we were just about to have another technical issue because I was just about to go and get myself a drink. But there you go. That's fantastic. Well done, Kirsty. I've been listening to the comments actually and getting lots of WhatsApp messages and things from people just saying how easy to listen to you are. So on a personal note,
thank you.
just on a purely personal note, well done. Thank you very much. I mean, it's really interesting. There's a couple of things that I've written down from the comments that have come through. The first thing I want to ask is we've got somebody watching whose name is Nelly Liverpool. I just want to check: is this the same Nelly that that has come to our JCN events that I've met a few times over the last sort of 10 or 11 years? Because I think it is. So if you can just confirm whether this is the same person, I'd personally really appreciate that. The second is a comment rather than a question from Leslie Smith, who said that the NHS should be standardised across the board when it comes to care.
Absolutely.
And I just thought that perhaps we could just firstly just have a little bit of a chat about that, because it seems really obvious, surely, that the NHS should be standardised across the board, not just. I know that we have devolved NHS systems in Wales. So what happens for those of you that are unaware? Here we have the Welsh Assembly in Wales. In Scotland they've got their equivalent, and we get given money from Westminster to run certain services, the NHS being probably the predominant one. But what it means is that in Wales, we're able to then decide on how we spend that money on the NHS. So we have very different, for example, cancer services, cancer screening services. We have different dental services. So we get in Wales, we get free prescriptions for any prescriptions and all the rest of it. So we've across there does seem to be a bit of a disparity when it comes to when it comes to the NHS, really,
Mm.
across the UK. So do you think that Leslie's right? I mean, I think I probably agree with Leslie. I think there probably should be standardised care across the
It's
NHS
a
across the
no,
UK. What are your thoughts?
it's a no-brainer, absolute no-brainer. And I think in England, obviously, Leslie, you work in England, they've got the National Wound Care Strategy, which has tried to get that standardization into practice. But I think you've got sequence that we don't have in Wales. So there's not that performance outcome that comes with it. In Wales, we are lucky that we're accountable to our CNO, and we do have our assistant CNO sitting on our group, which is really helpful. And that the TVNs in Wales are quite influential about bringing documentations to the forefront in local health boards and making sure that they're out there for use. But I agree with you, Lindsay. I just think it's a no-brainer. We do need that standardization across NHSs. And sometimes I think that is a failure that we have, is that every different health board or NHS trust is doing different things. We need to be singing from the same hymn sheet. And we have done that a lot in Wales, because we're starting to have a standardized electronic documentation across Wales that's been rolled out in the acute, and hopefully will be rolled out into sort of the community as well. So again, with that standardization of documentation, hopefully our document will link in with that as well.
Yeah, and I think that really the entire presentation is based around sort of promoting the fact that if you do work together across borders,
Yeah.
And we say across borders, I mean we're talking about sort of CCGs and various other authorities in England, that actually if you work with your counterparts in other counties and things like this, you can actually come up with guidelines that are
Absolutely.
that are relevant to that particular area. I mean, the idea that you'd get the whole of a single country to work together to come up with one
Massive.
single guidelines is
Yeah,
massive. Yeah,
it
I
is
understand it's
massive.
massive. I mean,
Yeah.
so let me ask you, when did this project start?
Well, this started before COVID, so that's how long it's been going on. And of course, COVID delayed a lot of the meetings and things, because everything was all up in the air. So it has been a long time coming, I have to say. But I think that every health board is on up for it. And I think as TVNs, we're going to be instrumental in pushing this forward. We've done it with our safeguard, our reporting and investigation guide. So we've already produced that document that goes with pressure ulcers. So that is now standardized across Wales. So we've managed to do it with quite a few of our documents. So I think it is key to get it across everywhere, really.
Okay, and you're discussing there are other guidance documents as well on things like we've had to chat around things on the use of larvae therapy,
Yeah.
negative pressure. There's some patient stuff that you're interested in creating. So actually, you're being very proactive in terms of creating consensus across the whole of Wales for many different subjects, rather than just what we're specifically talking about this evening in leg
Absolutely.
ulcers. Yeah.
Yeah.
Look, we've got loads of questions that have come in. I've got a ton of them here, so we'll get onto those if that's all right.
I'll try and answer
Um,
them as long as they're not too technical.
yeah, the first one is a really interesting one because it's we do a lot of stuff that is based around sort of leg ulcers, compression, lymphedema, all that sort of stuff. And this question is a question that comes up often. I read it earlier and thought, wow, that's a question that I've asked so many times. But I'll ask it again because it's obviously really relevant. So, can you give me any advice on how to deal with a patient who's reluctant to accept strong compression? We've explained everything to her, so it's obviously a specific patient in mind. And she's been involved in choosing the compression system we use, but is still reluctant.
Do you know what? This is a magic wand situation, isn't it? It's a heart sink. And I think as healthcare professionals, we've all been faced with this thing. So sometimes it's going back to the drawing board with her, going through all the documentation about and understanding why she's so reluctant to go into that high compression. I think that's understanding, giving her the opportunity to discuss it and share with you her views on how she's found the compression and what she's found difficult about it. And then it's having that discussion again. I know you've said that she's been, choosing the compression system, but has she been choosing the right system? So about showing her different sort of options for compression, and going through that process again about explaining, we understand your frustrations, but actually that compression is the thing that's going to heal your ulcer more than anything. And for me, sometimes it's about after the horse has bolted. So as I said in the presentation, when people walk through that door with a leg ulcer, you have to get them on side, get them on that journey with you. So it's about, as they come through the door with a leg ulcer, you're giving them that information about compression, what a leg ulcer is, about their veins, about what they can do about it. So you're empowering them from that first visit. But I do accept that when you've got somebody who's very resistant to exploring compression, it's very challenging. And my advice is to explore with her what her resistance is and see if you can come to some sort of common ground on that. But it's not easy.
Okay. Hopefully that I think that was pretty comprehensive. That answers the question. The next question is actually a question that I think I can probably answer, which is I'm a practice nurse. How will you ensure GP practice nurses have access to the document? So with regards to the document itself, our editorial director, Nicola, who's been managing this project magnificently, to be fair, this document will be probably ready for printing, I would say mid-January. So we're just looking at that. There's just some very, very final bits that just need doing, some editing bits. And once it's ready, a PDF version will be available via the Welsh Wound Innovation Centre website. It'll also be available via our Wound Care Today and our Journal of Community Nursing websites. And at the end of this presentation, you can download your certificate of attendance for your CPD records for revalidation. And as part of that, there's a question that asks you if you would like to receive a copy of this document. And we will take your details. You give us your details, and then as soon as the document is ready and printed, we'll post you a copy. So you'll have a hard copy and a link to the PDF, a digital version of the document as well. So keep an eye out. If you don't already, most of you will already be following our Facebook page and stuff like that. But if you don't, just follow our Facebook page, because the moment that it's ready, we'll be putting stuff out to let people know where they can find a link to be able to download it. So I think that's. You're happy for me to answer that question, Kirsty? Anything you want to add to that?
Absolutely. No, go ahead. That's fine.
Brilliant. So question number 3 is wondering, how do you manage with leg ulcers and compression in the acute setting? And this is from Donna.
Oh, Donna, yeah, that is a tricky one. And I know that some of the my colleague in the acute trust is looking at that specifically. And of course, sometimes when individuals come into hospital, they immediately go on bed rest, put their legs up, and their legs heal. However, we do know that it's an issue with training in sort of practice, definitely, because you have such a massive change around of staff on ward. Sometimes it's about how you can deliver something that's safe and effective. So you could always do the first line wet leg pathway that's advised in the lymphedema contract, lymphedema guidance. So that's yellow line, wool, and yellow line over that. Obviously, we want to maintain compression where we can. So if you haven't got anyone trained in compression bandaging, the other options are hosiery, if there's not a lot of exudate, or even consider compression wraps, because compression wraps are safe to, fairly safe with minimal training. So if you haven't got somebody who's sort of trained up in bandages, it might be that you've got to look at something else that's more appropriate in the acute sector. But ideally, we don't want to get those individuals out of bandages if possible. And if you've got somebody that you can train on the ward who's able to do the bandages, or a couple of people, that may be the option as well. And observed competencies as well.
Okay.
But ideally, you don't want to be taking them out of compression if you can avoid it.
Okay, brilliant. The next one is fairly this is from Luke. It says, what type of dressing products do you use on your leg ulcers, e.g. alginates, antimicrobials?
Well, I'm going to disappoint you here. We use very simple non-contact layers, non-adherent wound contact layers. Unless we've got some slough, we may use a product that desloughs, has some desloughing properties, or if there's an infection, we may use an antimicrobial, but we keep our wound contact layers really, really very, very simple. Sometimes if somebody wants to self-care and they've got a smallish sized leg ulcer to their leg, we sometimes use a foam, but that's very sporadic because of course we're worried about reactions to that. But if it maintains their individuality and they're able to support self-care and there's minimal exudate, then sometimes we'll go for an adhesive foam if that's the thing. But we keep it very simple and just probably use a wound contact layer more than anything. And I think most of my colleagues in tissue viability would agree the same thing.
Okay. I saw a question earlier. It's not come up on my sheet at the moment, but I saw a question earlier that we've had in the past, which is, can you use super absorbents under compression?
Yes, you can. Years ago, there was a myth that it changed the ankle circumference, which it does slightly. So, of course, again, it depends on what compression you're using. So if you're using a super absorbent, you're obviously going to have a very, very wet wound. So what you would need to do is put the super absorbent dressing on with your Clini-Fast first, or your yellow line, blue line, whatever it is. And then you'd have to measure your ankle circumference and make sure that your bandage system that you were selecting was correct for that ankle circumference. But certainly you can use super absorbents for managing exudates under compression.
Okay. Here's a question that my boss, I've got a boss, believe it or not, my boss Ed will love.
Ed!
That Ed will love, which is it's really specific, and I think
gosh.
and I know the answer to this anyway, but
well, I might not know.
It is what is your opinion about you? It's because this really isn't a UK thing. So I'm not sure where this person's from, but what is your opinion about adding hyperbaric oxygen therapy sessions to treat resistance to heal leg ulcers more than 4 weeks of standard proper wound care? So that's working on the assumption that hyperbaric oxygen therapy is even available, which it isn't really in the UK widely. So yeah, I mean that's something that I'm sure that you've come across.
Yeah, and I would, that we did have access to it many years ago. But actually, it's an expensive treatment. And I would say that if your wound isn't healing, you need to go back and reassess and find out why it's not healing. There are lots of treatment modalities for complex leg ulcers that you can use if the wound isn't healing. So hyperbaric oxygen wouldn't be one of my top go-to products to use.
Okay. There you go, Khaled. I think that's a fair enough answer for that. Next one, when can we refer the patient to vascular clinic?
So that does depend on your local protocol. The NICE guidelines indicates that if somebody's got a venous leg ulcer, obviously arterial ulcers do need to be referred as soon as possible. As soon as you think it's arterial, get them seen. With venous leg ulcerations, part of the NICE guidelines is that they should be referred for some sort of ablation if it's suitable and appropriate for them. So I would say if they've got a venous leg ulcer, get them referred to vascular. I'm not saying that they'll be seen soon, but as soon as you get that referral in, give them that opportunity to be seen by vascular surgeons. But obviously you do need to check your local referral protocol and policy.
Okay, brilliant. And then question number 7 is, can any professional or can any healthcare professional do compression bandaging, or can you only do it if you have competency?
Compression bandaging, you do need some competency in it, because if you put it on incorrectly, you can do a lot of damage. You can cause skin damage, you can cause tissue necrosis. So yeah, you do need some sort of training to apply a compression bandage But that's not to say that you can't have the training. So you have to look at what's available locally, whether your local tissue viability nurses will offer training, and sometimes look at what bandages you've got on your local formulary. And sometimes the companies will offer training and competency assessments as well. So I would say, yes, you do need some sort of training and assessment to put the bandage on safely. But certainly there should be some sort of availability of training from either your TVN service or maybe the companies that should be available. And also, if compression bandaging is an option, for example, in some of our practice nurses, they are not allowed to do compression bandage because God knows why, it's too tiny or anything. There are other options that you can look at. So, for example, if the wound or if the leg ulcer is not highly exuding, why not use a hosiery kit? Why not use a wrap? So we've got other options that we can use without that level of training that you might need to use for compression bandaging.
Okay. And Hugh James from Essity has commented and said,
hello, Hugh.
Hello, Hugh. Fernand he's
no, not with that.
Yeah, not at this time of night. Yeah, he's basically commented and said, "Happy Movember, Al." So I guess the question is, if we can just get a thumbs up or thumbs down, do I keep the moustache or do I get rid of it on the 1st of December tomorrow? Who knows? Well, Hugh, I'll let you know what the outcome is of that, and when I see you next, you can decide whether it's a good or a bad idea. Listen, Kirsty, thank you very, very much for this presentation. Can I just say again a huge thank you to our industry partners for supporting this, because actually what their support has done, and to be clear, there's some financial support that they've given, and what that's allowed us to do is to be able to, print pricing has gone through the roof over the last couple of years. The same way as many other things. And so what the support of industry has allowed us to do is to basically be able to print enough copies to make sure that it's seen across Wales. It's given us enough money to be able to do an event like this. We have an event that is a face-to-face event to launch this event or to launch this document again at we're currently looking either end of January, early February. We're just waiting for some dates. That's likely to be in Cardiff. So keep an eye out for that, because if you are in Wales, then there will be a face-to-face event, which is a full-day event, which is not just about this document, but is about sort of leg ulcer treatment in general. So we'll be announcing dates and things like that. And we just wouldn't be able to do it without our partners at Essity, L&R, Sigvaris, Haddenham, and Medi. So thank you very, very much to you guys. Kirsty, thank you very much. I'd like to thank my team. There's a link, should be a link in the questions site there where you can download your certificate. As part of that download, I know I mentioned this earlier, but as part of that download, there's a question on there which asks you if you'd like to receive a copy of the document. If you press that and then put in your details, we'll then, as soon as the document is ready, we'll then get a copy sent out to you. So we'll go. So thank you very much. And we look forward to seeing you at our next event, which is on the 6th of December. So that's next week. And that's on diabetic foot ulcers. So go onto our Facebook page, have a look at that. That's a really, really interesting event with some fantastic speakers. That's all to do with our Microworld, our animated learning platform. So please do join us next week, because that'll actually be the last event that we're doing of 2023. We'll then be finishing for Christmas. Yeah, thank you very much, Kirsty. Good night, everybody. Good night. Look forward to seeing you soon. Bye-bye.
Bye-bye.